Go ahead with the next talk by Dr. Mohammed AlMutlak. Dr. AlMutlak will be talking about high-risk corneal transplant indication and post-operative management. Dr. AlMutlak is an experienced corneal surgeon working in Kekish, where is a referral center for all the complex cases. So he will share us the experience of Kekish today.
So, good morning, everyone. So my talk today intended to review high-risk penetrating keratoplasty. It's a review for the literature and supposed to lay the ground for the coming lectures. So penetrating keratoplasty is the most common form of solid tissue transplantation, and high success rate of uncomplicated avascular low-risk beds contrasts sharply with the so-called high-risk beds vascularized, which rejection can reach up to 70%. Immune-mediated rejection remains the leading cause for corneal transplant failure. So two factors play a role in PK success. One is the unique anatomy of the cornea, which is responsible for the lack of immunity, and two, the degree of vascularization and the condition of the host bed. In this talk, I want to focus on two questions. One, what's a high-risk keratoplasty? And two, how to approach these cases. So whenever we think about these cases, we have to think about it in the context of timeline. It's what we do before keratoplasty and what we do after is the important thing. During, there is no much difference. So there are few risk factors for developing rejection and failure. One, most importantly, corneal stromal vascularization, prior graft loss, and increased graft diameter, anterior synechia, glaucoma, previous intraocular surgery, and ocular surface diseases, and finally, pediatric keratoplasty. So if you look at the collaborative corneal transplantation study, they defined high risk as cornea with two or more quadrants of deep stromal vascularization. And if four quadrants were involved, the risk was doubled, but not just the degree and the depth of preoperative corneal vascularization determine the onset and the severity of rejection. So pre-treatment is key with steroid, cyclosporin, anti-VEGF, or other modalities such as mechanical ablation or injection of mitomycin and so on. A previous graft failure is a significant risk factor for transplantation, especially if it was related to a previous graft rejection. Graft rejection tend to be more aggressive and occurs early in cases of regraft. In the cornea donor study, it has shown an increased risk of graft failure in those with a history of definite graft rejection episode. Any direct contact between the host and the donor through peripheral anterior synechia predisposes patient to developing rejection and failure. And just like vascularization, involvement of the four quadrant with anterior synechia will put the patient at a doubled risk of rejection and failure. Any previous intraocular surgery, whether lensectomy or vitrectomy or glaucoma, because of the exacerbated inflammation and the sequelae of surgery such as vascularization and synechia, they tend to develop rejection and failure. So inflammation at the time of surgery is a significant risk factor, and keratoplasty should be delayed until inflammation is well controlled for a period of 6 to 12 months. Other difficult etiologies at risk of rejection and failure, OCP, Stevens-Johnson, and collagen vascular diseases. And one typical scenario is patients with atopy and keratoconus. They tend to develop an aggressive inflammation after keratoplasty called post-keratoplasty atopic sclerokeratitis. They present with conjunctival injection, loosening of sutures, and vascularization. Pediatric keratoplasty is also a high risk due to the robust immune system and patients with healing issues and limbal stem cell deficiency, such as aniridia and chemical burns. Intraoperatively, one factor that we can eliminate is the quality of the graft. Ensuring a good quality of graft will eliminate the confusion. Using interrupted sutures will allow you to tailor your management, and the release of the synechia and surgical PI and addressing vessels at the time of surgery will also help. Postoperatively, the management depends on three factors. One, patient education and follow-up. Two, the topical medication and systemic immunosuppressive agents. And three, the management of complication. So the basic goal is to prevent rejection ahead of time by recognizing it early and treating it earlier so that you get a good outcome. So teaching patients about redness, sensitivity of light, visual loss, and pain, signs of rejection, and a frequent follow-up will allow you to pick these cases ahead of time. Being aggressive with treatment of any trace of inflammation, keratic precipitate, asymptomatic subepithelial infiltrate, conjunctival inflammation before the rejection start is a good idea. And topical steroid, it's recommended to start it with a very high frequency and then taper it for indefinite use, assuming that there is no contraindication. In cases of ocular hypertension, Lotimax is a good option. However, the efficacy is lower. Systemic steroids can be used. It's a bit controversial, but can be used during and post-operatively until a more specific immunosuppressive agent kicks in. Cyclosporin A acts on preventing T-cell activation and most prominently interleukin-2. Studies have demonstrated that topical cyclosporin A has an additive effect to steroid. And even at the systemic level, cyclosporin A is used in high-risk cases. It's a good long-term strategy, specifically with patients with atopy. Since the graft survival is decreased, it can be improved with the use of cyclosporin. However, the effect fades away once it is discontinued. So it's recommended to continue cyclosporin during until the sutures are removed. Other option, topical tacrolimus. Topical tacrolimus is used off-label as a second-line agent for immunosuppression in cases of keratoplasty. And a recent study looked at the combination of topical tacrolimus and Pred40 versus Pred40 alone. And they concluded that the combination did better than monotherapy alone. Now, when they looked, in a different study, they looked at topical tacrolimus head-to-head with cyclosporin A, and topical cyclosporin A showed clear benefit compared to cyclosporin A. Systemically, tacrolimus can be used. However, renal toxicity and hypertension can occur. There is a superior effect when tacrolimus was compared to cyclosporin A. One interesting drug is mycophenolate mofetil. Mycophenolate mofetil acts as an antimetabolite. It blocks both T and B cell, and it decreases the incidence of immune reaction and may have a promising effect in cases of high risk. There are a few papers that talked about the benefit of using mycophenolate mofetil as a first-line agent given its safety and its excellent result. Other modalities that can be utilized to prevent and manage complication: amniotic membrane transplant, tarsorrhaphy, surgical PI, and glaucoma surgery to control the IOP, and limbal stem cell transplantation. And finally, I want to keep you with few take-home messages. One, treating preoperatively will help and is important, as important as the intraoperative and postoperative period. Educating patients and picking cases will get a good outcome. Intense topical steroids with either cyclosporin A or tacrolimus is helpful as a long-term strategy. And systemic mycophenolate mofetil is an effective first line in high-risk keratoplasty as a single agent with a good safety profile. Thank you.
Thank you, Mohammed.